Thanks, Jens. I appreciate the opportunity to speak again here. I'm taking the place here of Dr. Sansor, and I'm going to stay focused on deformity. So this will be the adult deformity techniques talk, which I think is labeled 1045. So I'm going to try and keep on time here in case stay to 20 minutes or so. And specifically, what I'm going to focus on is again, surgical techniques for adult deformity. And as I said earlier, my theory is that I really want to try and focus on three main topics. And those topics are number one, when we're dealing with correction of deformity in the adult, there's a spectrum of techniques. And as I talked about in the anatomy lab, that spectrum goes from our posterior facet resections to our three-column osteotomies to our vertebral column resections. So we'll go through that spectrum briefly. The second thing I really want to focus on is the notion of creating a balance in our correction, or a matched correction. So recognizing patients who have perhaps double major curves, or really important patients who have a long thoracolumbar curve and then a sharp fractional curve for L4 to S1. So recognizing that when we're correcting deformity, that we want to keep those deformity, keep our curves well balanced, because usually there's some differential in the stiffness between those curves. These are, again, my disclosures here. I don't think they're relevant here. This is really, I'm going to focus on techniques. And then the third issue I really want to bring up, I talked about earlier in response to a question, but this notion of what's the difference between getting angular correction. So when we do our Smith-Petersen osteotomies, or when we use compression distraction techniques, we get angular corrections versus actually translating the spine. I think that's an awfully important concept when we get into the realm of vertebral column resections. So again, these are the three main points. Thinking of osteotomies as a spectrum. And what I mean by that is that oftentimes when I'm doing a deformity, for example, if somebody's got a pseudoarthrosis and a multi-level fusion, and I'm thinking about doing a pedicle subtraction osteotomy, I'll take out the rods and find out that actually there's multiple levels of pseudoarthrosis in there, and it's frequently that I don't actually need to do a three-column osteotomy. So I'll start off with my facetectomies and find out that I've really got a surprising amount of mobility there. I'm going to get into that in more detail. So that's the overview. Again, I think in recognition to Professor Dubousset, recognizing that our correction is going to be in three dimensions. So our sagittal plane corrections, this is another example of a type 1 congenital kyphosis. Our coronal plane corrections, so our patients who have more of a horizontal plane deformity. And then finally, our rotational or more complex deformities. And really trying to get our correction in all three planes. A lot of variability in how we do these surgeries. And you heard earlier that I've gained confidence in doing these surgeries, a lot of correction from the back. Having said that, I still think there's some real advantages to anterior surgery. So whether we're here in Seattle or down here in San Francisco or where I trained in Boston, a lot of variability in how these things are done. I do still think there's a great role for anterior surgery. And specifically what I mean by that is that we get a very effective arthrodesis with big bone surfaces in the anterior column of the spine. We're able to really mobilize the spine very well. And in many instances, I think by going anteriorly, especially my adolescent idiopathic cases, I can save levels. I could do a shorter fusion in the adolescent. I can often stop at L3 in the front, where I'd have to stop at L4 in the back. In osteoporosis, as Paul just talked about, certainly we get much better stability with some anterior column support. Whenever there's ventral compression and neural elements. And this last point I want to emphasize is the most common reason that I go anteriorly first for correction deformity is when there's a real stiff fractional curve from L4 to S1. I find that really difficult to get L4 horizontal from the back. So I'll virtually always do that with an ALIF. And I'll show you some examples to really bring that to light. Show you examples where that's gone wrong and where it's gone well. In terms of surgical technique, how do we do the anterior approach? I thought we had a very, very nice talk by Jacques about how to what we can do anteriorly, including releasing the ligament. When I first trained, this picture on the right is a long thoracolumbar exposure. We used to routinely on Thursday go T10 to S1 in the front, so we take out the 10th or the 11th rib and then just do a long exposure. And that's what Professor Dubousset was talking about, getting correction. And then in a staged fashion next Tuesday, going in the back. And our infection rates were 10 or 12% with those big stage surgeries. It's very unusual that I would do that now. But I think there are some real advantages as a technique to addressing deformity from the back, especially for double major curves. We can oftentimes manage this through a single incision, keep a balanced correction. The exception there being, again, that stiff lumbar sacral curve that I'll talk about. We can get good decompression neural elements directly, good pulmonary tolerance, single-stage surgery, single-day surgery. I think with T-lifts and PLIFs, we can get a good anterior interbody support. And again, with osteotomies, we can really mobilize the spine very well and get a lot of correction. So most of the time, I'm getting most of my correction with posterior osteotomies. And again, I describe the osteotomies as a continuum. And I just want to make the distinction going through each of these a bit. This is from a chapter that Dave Redford and I put together last year for the updated Master's Technique in Spine Surgery. And specifically, I make the distinction here between what Ponti described as an osteotomy, where you're moving through a mobile anterior column, and the Smith-Petersen osteotomy. And basically, this is a continuum going from a facet resection with moving in the anterior column to actually cutting some of the anterior column with our pedicle subtraction osteotomies and our vertebral column resections. I'll go through each of these with examples. So, and Frank Schwab talked about this as well. He talks about really 6 degrees of destabilizing the spine. Partial or complete facet resection. So the Ponti or the Smith-Petersen, you're taking out that posterior facet, closing and gaining mobility from the anterior column indirectly. Our pedicle subtraction osteotomies, we would take out part or of the vertebral body as a wedge, with or without the disc. Then our vertebral column resections, where we might take out the complete vertebral body with the disc above and below, or in some cases, multiple levels. And that's sort of sequentially mobilizing the spine more and more. I think it's awfully important to recognize the scenarios of preoperative flexibility. And sometimes this can be masked in a patient who's already got instrumentation in place. We may under-recognize how correctable somebody's deformity is. And certainly in our really flexible, passively correctable spines, that typically is our adolescent patient or a patient who hasn't had prior surgery. Those cases, it's very rare that we need to do a 3-column osteotomy. Lenke described this in 3 types: a stiffer curve, and then the stiffest is somebody who's actually fused. And a lot of times I'll use x-rays, including dynamic images, to take a look at how stiff the patient's spine is. So when I'm thinking about how much do I need to mobilize the spine with surgery, the first thing I want to know is how much can I get on a table? So we'll use bending films. I'll oftentimes use extension films over a bolster. Oftentimes I'll use traction as well. Sometimes our advanced imaging, our CT scans and MRI scans can be very useful because the patient's in a supine position, oftentimes for a prolonged period of time for these images. And when I see somebody who has a big vacuum disc in the front on a CT scan, or I see how well somebody opens up on an MRI scan, then I know automatically that on the table, adding a resection of the posterior facet joints, I'm going to get a really dramatic correction. And I don't necessarily need to have a 3-column osteotomy. Similarly, in somebody who's got a non-union with implants in place, once I take out those implants and really start exploring the fusion, oftentimes that spine will sort of fall into a much greater lordosis. So when I'm trying to measure my lumbar lordosis and pelvic incidence, I'll be interested in a discussion for the opinions of others on this, but I actually take my lumbar lordosis off of a supine image, be it an MRI scan or a CT scan. I'll look at that as my starting point for how much correction I use. I won't necessarily look at my standing image because my supine image gives me a much better idea of how much lordosis I'll get. So again, moving through the spectrum here, Ponti really described his posterior shortening for kyphotic correction in patients with Sherman's kyphosis. And again, the correction comes from a mobile disc, and we can get typically 8, 10, or even more in a lumbar spine, maybe 12, 15 degrees of correction by if you've got a really mobile disc. That's particularly useful in our adolescents and our Sherman's patients. And just a couple examples here. Here's a young adult. He's actually, I think, 28 years old. He's a big weightlifter. He's got an atypical Sherman's at the thoracolumbar junction. And it appeared quite stiff, but, in the MRI scan, you get a sense of how much those discs are going to open. Oftentimes, I'll put somebody over a bolster. So this is him supine with a bolster on his back. You get an idea of how flexible this might be. Sometimes I might consider doing a thoracoscopic anterior release, but in this case, I did this all in the back with Ponti-type osteotomies and mobilization through the disc. The more extreme example, the Smith-Petersen, Marius Smith-Petersen practiced at the Deaconess Hospital in Boston, and he actually comes from my hometown. He's from Grimstad, Norway, and he trained in Wisconsin. I don't know, Paul's not here right now, but my family's from Grimstad in Norway. And he's very famous in orthopedics for the work he did in the hip. But he also was a spine surgeon. He did a lot of work with rheumatoid spondylitis. And what he described in these rheumatoid patients was putting them prone on a table, taking out the facet joints, and really gaining, this is from his article this was published in 1945, I believe, in JBJS, where it's actually an osteoclasis, where he's getting about 30 degrees of correction by cracking that spine. So sort of like has been done in a cervical thoracic junction up in Buffalo, actually cracking the patients with ankylosing spondylitis. And this is a much more dramatic and focal correction of deformity, so somewhat different than what we're really seeing in a Ponte. And that's where I think that's a distinction that's worth understanding. And here's a patient with ankylosing spondylitis of mine, where I got most of my correction through the PSO at L3, but also at that thoracic hyperkyphosis, I actually did Smith-Petersen osteotomies across there and actually cracked that anterior column to get a more harmonious correction of that thoracic hyperkyphosis. And this is a case where I thought I might have had to actually do 2 PSOs, but with some Smith-Petersens above and a PSO, I was able to get an adequate correction on that. Here's a patient who had a Sherman's kyphosis, was fused in a poor posture. So again, with good posterior-based osteotomies, I was able to get some osteoclasis on the levels where there's a circumferential fusion. You see the dramatic improvement of that patient's deformity with an all posterior-based approach, including T-lifts at the bottom. So that's the Smith-Petersen portion. And again, the correction is osteoclasis with the Smith-Petersen versus through the disc in the Ponte osteotomy. And I've found that this is really quite useful for a lot of cases, especially when there's not a prior circumferential fusion. So most of the cases where I'm doing a 3-column osteotomy, meaning where I'm doing a wedge resection, not so much a VCR, I can talk about that separately, but most of the cases where I'm doing a wedge resection and taking out either a wedge of bone or a wedge of bone and disc are really patients who have already got a circumferentially fused spine. Early in my training, we used to do a lot of ankylosing spondylitis. I just don't see that as much anymore. I don't know if anybody is with the TNF-alpha inhibitors, but patients who have already had a circumferential fusion in malalignment. And I described earlier what Heinig described as this decancellation. And I still use this technique of decancellating the vertebra. I think it really limits my bleeding. But the way I did the technique was really described by Thomasen as taking a wedge of bone out with or without the disc above, and essentially closing that wedge and hinging on the anterior column of the spine, typically to hinge it on the ALL. Here's a couple of examples. Again, another patient with ankylosing spondylitis, very rigid deformity, and we're able to get a very nice correction of deformity with the 3-column osteotomy. That spine is not going to be mobile with a Smith-Petersen or with a Ponte type approach. Perhaps I could have gotten something better or I could have gotten as much with the Smith-Petersen approach, but that doesn't end up being a very harmonious correction either. Cracking that anterior column, I think, can be hazardous, especially in our older patients. And Smith-Petersen actually had 2 patients die of bleeding from extending that anterior column without visualizing the vessels in the front. Pre-op to post-op there. I'll show you with some humility a couple of other examples, and this is going to transition into the talk about translation of the spine. So this is a patient who's a nurse at UCSF, had surgery elsewhere, and she's got a significant sagittal and coronal plane deformity. And this is a nice example of a case where we can use the asymmetric pedicle subtraction osteotomy to actually get correction of both the coronal and the sagittal planes. And I think that this is quite useful for some coronal plane deformity as well. But I want to point out the limitations of this. And I think the next case maybe shows the limitation a little bit better. Here's a patient who had surgery actually up in this part of the world some time ago. Actually had multiple surgeries over her years. She's now 38 years old. She's a lawyer up here in this area. And you see she's got level shoulders. She's got a trunk shift. Her trunk and pelvis are imbalanced. And this is really what I called earlier that type 2 deformity, where an angular correction alone here, I'm concerned that that might throw the shoulders off. So she's got a sagittal and coronal plane deformity. And I did this surgery quite a long time ago, actually. This was over 10 years ago. And I don't think I was quite aware at that time. So I'll show you, I think everybody would agree, a nice correction. Professor Dubussy is not here, so I feel a little more confident about showing my post-ops now. And nice correction in the sagittal plane. But in the coronal plane, I think if I were to be really critical here, I think I elevated her left shoulder a bit. And what I did here is I did a asymmetric PSO. And again, in closing that osteotomy, that wedge asymmetrically, essentially I'm getting an angular correction, but I'm not really translating the spine. and maybe I'm being a bit nitpicky here, but I think that that left shoulder is up a little bit. And that's an example of where our angular techniques might be limited. So again, the second major point I want to bring home here, the first major point is the osteotomies occur as a spectrum. And after I've done my facetectomies, only then technically can I begin my 3-column osteotomies, and only then do I really know how much correction I need sometimes. And oftentimes I'm very pleasantly surprised after I do my facetectomies how mobile the spine is. So this idea of angular correction versus translation, this is actually, I think this exemplifies this nicely. It's a case of my mentor, Dr. Bradford, but it's one of the better examples I've seen. And if we think about trying to correct this patient's deformity with angular techniques where we compress across the convexity or distract across the concavity here, we're either going to exacerbate the trunk translation or we're going to exacerbate the shoulder asymmetry. So an angular correction technique is not going to work very well here. And what we really need to do is we need to actually translate the spine. And this is what introduces the idea of the vertebral column resection. So again, a type 1 deformity here on the left, when the convexity of the, in this case, the thoracic curve on the left, is on the same side as the shoulders, then I can go ahead and compress the convexity, distract the concavity, and level the shoulders and keep everything balanced. When the convexity of the deformity on the right-hand side is on the same side as the trunk translation, suddenly the more I try and correct the deformity, the worse I'm going to make the trunk translation. Or at the bottom, if I try and correct that lumbar convexity, the worse I'm going to make the shoulder asymmetry. So that's the point where I really need to translate the spine. And again, I credit Dr. Bradford for this, and his technique was to go in the front and the back. But the technique here of actually taking this patient, taking out 2 or 3 apical vertebrae, and then translating her trunk back over the spine. If that was done with an angular technique, it would either result in an exacerbation of shoulder asymmetry or an exacerbation of trunk shift. So that's where I think understanding that trunk translation, that's the key to what we're trying to do with a vertebral column resection, is translating the trunk back over the pelvis. And there are many instances in complex deformity where that just can't be done with our standard angular techniques. Keith Bridwell wrote about this as well, and this is where we get the idea of a type 1 and a type 2 deformity. So again, the type 1 is a pretty simple correction, where if we do osteotomies across the convexity and Smith-Petersens, we can level the shoulders and bring the shoulders and pelvis into alignment. The type 2 is the exact opposite. So you see here, if we do osteotomies across the convexity of that thoracolumbar curve, we exacerbate the trunk shift. So the type 2 is where we need to translate the trunk. And again, that's where our vertebral column resection comes in. And I'll just show you a couple of examples I think that'll show this well. I talked earlier about the fact that I learned how to do this as a combined anterior and posterior approach. I think there's a lot of morbidity to that. In my hands, I virtually always do this through a posterior-based approach, and I credit both Professor Suk, who spent some time with us in San Francisco and who I visited in Korea, and also Professor Lanke, who I've visited several times in St. Louis, for really teaching me how to do this from a posterior-based approach. Here's a couple of examples. Patient with significant trunk translation. Now, she's 68 years old, long-standing deformity that's been getting progressively more disabling. Somebody had the idea, well, I'll just treat your spondylolisthesis at L5-S1 and took care of that bottom of the curve. And sometimes that's a reasonable option, but clearly that didn't help her overall malalignment or her deformity. And this is one where if I try and do compression distraction of that thoracic curve, I'm just going to exacerbate her trunk shift. The only way for me to get her back to balance is to take out those apical vertebrae. So in this case, from the back, I took out L1 and L2 and brought her back in. I think I got a pre-op to post-op. So brought her trunk back over her pelvis while keeping her shoulders reasonably level. And in the sagittal plane, perhaps most importantly, got a real correction of her sagittal plane deformity. But that's a big operation. I had to take out the L1 and L2 vertebra completely, put morsalized bone in there, shorten her column, and realign that. I think I've got I thought I had another example, but basically that was the second major point I wanted to make, is I want people to understand the difference between angular correction, which works in a lot of cases. It works basically if the shoulder is elevated ipsilateral to the convexity of the spine, angular correction works terrifically. In a patient where we don't have that type of deformity, where we've got a translation of the trunk, oftentimes angular correction can exacerbate our deformities, either our shoulder imbalance or our trunk imbalance. I'm going to move on. This is my third major point, is just talking a bit more about some larger coronal plane deformities and the idea of gaining a balance in the correction. And these are a progression of cases. I'm going to focus on the cases here, like the one on the right here, really large deformities, and what do we know about techniques for this. And what I really want to emphasize is the notion that when we see a balanced deformity, meaning somebody stands, even though they've got a big curve, say this example on the right, their shoulders are reasonably level, there's not a big trunk shift. The real danger in these cases is correcting those curves asymmetrically. It is really easy to just kill that thoracolumbar curve. I can get that straight all day long. But the problem is that the thoracic curve is a lot stiffer. So when we start getting corrections that are asymmetric, we gain real problems. So the third major point is I want to emphasize recognizing a balanced correction deformity. Maybe the simplest example is the patient with a lanky 2 or a king 5, so a double thoracic curve. This is in the thoracoscopic surgery days, all the time you'd see these people with an elevated left shoulder getting an anterior correction of the thoracic deformity, elevating that left shoulder further. This is a really tough case to keep those shoulders balanced. And what I do is I go up higher. I went up to T2 on her, and it's really challenging to not postoperatively, when you get a good correction of that thoracic curve, to not have that left shoulder elevated. So number one is recognizing it, and number two is trying to balance the correction. As I didn't necessarily hit a home run and get her thoracic curve completely corrected because that upper thoracic curve was really stiff. So keeping it balanced is more important than the actual amount of correction. And I won't belabor the lateral that Dr. Dubas says here. Here's another 65-year-old patient, pretty flexible deformity. On these double major curves, I'll actually get traction. So you see that middle x-ray? That's my fellow holding the arms, and either an x-ray tech, sometimes me, sometimes the resident, holding the legs, and really putting that patient on supine traction. And you see here that typically that thoracolumbar curve is much more flexible than that thoracic curve. And the real challenge here is making that balance. So postoperatively, making sure that you don't overcorrect the thoracolumbar curve or undercorrect. So your correction's got to be done in a balanced way. And that's where I think posterior surgery helps a lot. Let me show where that goes wrong. Here's a patient who had surgery down in the Los Angeles area, had a prior spine fusion from T5 to L5. And again, she had preoperatively a double major curve, really stiff thoracic curve, pretty flexible lumbar curve. And we see this all the time, is this asymmetric correction where now she's got a real deformity. So before her surgery, she was well balanced. Now she's shifted towards the left. She's got shoulder asymmetry, and she's got a flat back deformity. So this is a tough one. She's 42 years old. She wants to water ski. She wants to snow ski. She's got a fusion. I didn't want to fuse her down to the sacrum. She's sexually active. All the reasons I don't want to go down to the pelvis. So, and this might be controversial. I'll show you what I did here, is I wanted to correct her sagittal and her coronal planes. And what I ended up doing, and this is just a close-up of her junctional kyphosis above, and she's got limited mobility here. At first, I was just going to take her down to sacrum, but I did an asymmetric PSO at L3 here, and I'll show you pre-op to post-op. And what I was able to do is bring her trunk back into balance by closing it asymmetrically and restore some lordosis. And I guess I did it at L2 and keep her fusion down to L5. So the point being that I actually increased that lumbar curve, because I don't necessarily have to have a straight spine. I want to have a spine where both the curves are balanced. It was much easier for me to increase that lumbar curve to balance her thoracic curve than it would have been for me to go in there and do a bunch of osteotomies across the thoracic curve and try and correct that. So I actually increased her lumbar curve. And you can criticize that later. But I thought that was a reasonable way to get her back into balance. Here's my final point in terms of anterior surgery. I think I'm just about to wrap it up here. Is that lumbar sacral fractional curve. This is a variant or a type of a double major curve. And I think I'm going to start off with an example here. So here's an example where it goes wrong. It's not a big fractional curve here from 4 to 1, but you see 4 is kind of oblique, tilted downwards towards the left. And this is a patient who had another surgery down in the Los Angeles area, very enthusiastic about doing something minimally invasive. You see she's got a pretty significant loss of lordosis as well. So we can kill that T11 to L4 curve. I can correct that all day long, and that's something that corrects on a bending film. And we got limited films preoperatively. These were from before I met the patient. But here's where I met her, is postoperatively. a beautiful correction of that thoracolumbar curve, but then that L4 is still oblique. And when you leave that L4 oblique, that patient is still tilted off to the left, and of course the sagittal plane is really malaligned as well. These are the cases where I tend to go in the front. And let me show you an example of one of my cases. This is a patient, she's 68 years old. She's a marine biologist who spends her summers in Hawaii and her winters in Alaska, and she actually finished in the top 3 of the Iditarod some time ago when she was younger. But the point being that she's got a trunk shift to the left, significant loss of lumbar lordosis. And in this type of case, when I see that L4 that's really oblique, see if I show you a close-up here. When L4 is really oblique, I have a tough time getting that horizontal all from the back. So one of the things I'll do is I'll actually go to the front, and this is where I really think anterior surgery is useful. I'll horizontalize L4, in this case even L3 from the front, and that then dictates to me how much correction I can get of that T11L3 curve, or the T11L4. So that T11L3 or T11L4, that is really flexible. I can correct that all day long. What's rigid is the L4 or the L3, the S1. So I'll tend to go in the front, 3 or 4 to 1, horizontalize that, and then go to the back. And again, in my hands, you see how she doesn't really bend out very well. She's pretty stiff there, 3 to 1. And in my hands, I have a tough time getting that 4 to 1 horizontal with a T-lift. Now, I love doing T-lifts, and I'm very comfortable to take out that concave side and distract in the concavity, but it just doesn't work as well as it does with an A-lift in my hand. So I did an A-lift 3 to 1 on her, and then went posteriorly. And again, you see relatively a balanced correction where I got L4 not completely horizontal, but more horizontal. And then that dictated how much correction I could get from 10 to 4. And I consider that another variant of a double major curve, is recognizing how easy it is to correct 11 to 4, but pay attention to that 4 to 1. Make sure you correct that fractional curve, because so often these patients will be off to the left after surgery because you did such a nice correction of that T11 to L4, but didn't correct the L4 to S1. This is just an algorithm, and any of you are welcome to my slides or handout, but this is one that Keith Bridwell put together about that type 1 and type 2 deformity. But I think the take-home message here is that if a patient can recognize the difference between the limitations of an angular correction, where the shoulders have to come towards the convexity, and a translation where you can dissociate the shoulders and the convexity. And then finally, the algorithm that I tend to use is I really like my Ponte osteotomies for a flexible anterior column, especially for patients with pseudoarthrosis, where I get a large, gradual correction of deformity, very harmonious correction. I think the Pontes are really useful there. The Smith-Petersen I do use in patients with prior fusions, where I got to get correction by actually cracking the spine, and it takes some force there. More often I'm doing Pontes with a flexible anterior column. In a fused spine, the transpedicular wedge resection is excellent. The limitation there is that when I close my pedicle subtraction osteotomy, when I close that asymmetrically, again, I'm angularly correcting, so I can't translate that. So I got to be very careful not to elevate the left shoulder when a patient starts off with shoulders horizontal. The vertebral column resection is what I use when I actually need to translate the spine and for my larger deformities. And don't forget anterior posterior surgery. I really think in patients with a fixed obliquity from 4 to 1, patient with a pseudoarthrosis, the anterior surgery is very useful still, even though I tend to get most of my corrections from the back. So that's an overview of really the techniques that I use for my deformity correction in the adult. I'd be happy to take some questions, please.